Good evening and welcome all to this Hatke seminar, which is arranged by Raigad branch of various organizations. And I am Dr. Chitra Kulkarni, who is currently president of Adolescent Health Academy Raigad branch. Recently, I'm happy to share that we got best branch prize among all city branches in India, and it was for the same like Hatke program of self-defense. So this is also an important part of our day-to-day practice, that we get lot of emergencies, and especially when the parents, both the parents, mother, father are working, and there is always scarcity of the elderly people in their house, and children are very, very experimental. So all of us, including the general practitioners, may get lot of issues related to unknown poisoning, and for that we are having a eminent and national speaker, Dr. Minash Sheikh, for further proceedings. Now may I invite Secretary of AHA Raigad branch, Dr. Sunita Ingre. Over to
Thank
Dr.
you.
Sunita.
Yeah, thank you, Chitra. And greetings from Raigad AHA and IIP Raigad branch. Uh, I would like to welcome all the distinguished guests and our speaker and our audience to this wonderful webinar, which is a very important topic actually, and we should be really up to date on this. And before that, I will request Dr. Neha Singh to go ahead and introduce our guest and speaker of the day today. Neha is the chairperson of Maha IIP Women's Committee. Over to you, Neha.
Thank you, Sunita ma'am. Good afternoon, everyone. On behalf of MAHA-IP and MAHA-IP Women's Committee, first of all, I would like to congratulate Dr. Chitra Kulkarni ma'am, Sunita ma'am, and Dr. Nilima Bhandarkar ma'am from AHA Raigad for organizing such webinars which are extremely beneficial for our adolescent and our young generation age group people. I also congratulate both Team AHA Raigad and
वो मेडिसिन ज्यादा नहीं खानी है ना वो तीन
Best
diet
Brand
of CTD
Award
and वो
at All India Adolescent Conference in Amritsar this year, also receiving the Best Branch Award and Charity Awards
बंद ही
for
कर दो
breastfeeding
आपके पास
at
रखो से
Pedicon, Thane this year. So in absentia, I welcome Dr. Ramakant Patil sir, President of Maharashtra Academy of Pediatrics, as well as he is also a Central IIP EB member and his team for today's webinar. Dr. Sonali Shirbate ma'am as the chairperson of MAHA-IP Women's Committee. They both will be joining us soon. I welcome RMA President Dr. Arun Kumar Bhagat and Dr. Rajesh Sakpal. He is Secretary of Raigad Medical Association. I also welcome President IIP Raigad and President IMA Ulve, Dr. Vikas More sir, as well as Dr. Krishna Borkar, Secretary, and Dr. Pradeep Atkari, Treasurer of IMA Ulve. We also have with us Dr. Rahul Veer, ex-Vice President, RMA, and Arun Kure, ex-President, NMDF. I also welcome Dr. Jay Bhandarkar sir as President of Rotary Club of Panvel Industrial Town. Welcome all of you for today's webinar. And the topic for today's talk and discussion is common childhood and adolescent poisoning, evaluation and treatment. I think it's a very important topic for we general pediatricians as well as general physicians, as we get our or might get these type of children in our OPDs, and we should be able to look for and properly manage them. And for this, we have with us our eminent expert and speaker, Dr. Minash Sheikh sir. Just a minute. Yes. We have with us our eminent expert, Dr. Minash Sheikh sir. He is from Lilavati Hospital and Research Center, Mumbai, lead head of PICU and ICU, Coordinator Department of Pediatrics. He, sir, is Editor-in-Chief, Jimle 2020, Associate Editor, General of Pediatrics Critical Care 2022-23, EBM Pediatric Intensive Care Chapter 22-23, Treasurer of Intensive Care Chapter, Maharashtra 2022-23. Sir is excellent teacher for the postgraduate medical students, and Sir has been faculty at various national conferences. He has penned down 35 publications, including book chapters, and his area of interest is critical care and infectious diseases. So I welcome you, sir. And from my personal experience, also, I know that Sir is a very humble person, as he has been my expert and judge in one of the Maha-IP programs. He had been very humble and helpful to me. So I welcome you, sir, and I now hand over to Dr. Sunita, ma'am. Over to you, ma'am.
Thank you, Neha. I will just request Dr. Vikas More to welcome our, as he is the president of IIT Raigad branch. Dr. Vikas More, brief.
Yeah, thank you so much, madam. I'm so proud to host this CME today. And as you all know, madam has already told, our AHA Raigad is asset to IIP Raigad because they are doing such a wonderful activities throughout the year. And it has been shown that they have been appreciated at national level as the best town branch in all over India. So this is a very rare achievement, and our team has done it. Secondly, Dr. Minashik sir has graced this CME. He has consented that he will guide us for this very important topic. I know him because he was my assistant professor while I was a lecturer in Grand Medical College. So I have a very old relations with sir, and sir is very humble, very knowledgeable, and always open to help at any point of time. And friends, we all know that this CME has been jointly hosted by various branches like Indian Medical Association Ulve. So I am a president of the same branch, and my able secretary, Dr. Krishna Boykar, who is a gynecologist, he has also joined. And his our treasurer, Dr. Pradeep Patkar, who is a radiologist, he also joined. Then Dr. Jay Bandakar from Panvel Industrial Town Rotary Club, and also most importantly Raigad Medical Association, which is a very big organization of 4,000 members. Dr. Arun Kumar Bhagat sir has also joined this CME. It underscores the importance of the CME. We know that this is a very important topic, and the little kids, children or adolescents are exposed to such kind of poisons in our day-to-day life, and we should have some knowledge how to handle these kind of situations. So over to you, Andrew, madam. Please carry forward.
Thank you, Dr. Vikas. Now, I'll request all the participants who are there on the Zoom platform to mute themselves so that the speaker is not disturbed. And now, over to Dr. Meenakshi, sir.
Yeah, thank you. Neha madam, can you please share the slides? Yeah.
काही नाही बोलायला चान्स आता नंतर बोलू.
Okay. Thank you. At the outset, let me thank the organizing team, the AHA Raigad, the IIP Raigad, in association with Maharashtra IIP Women Committee, Raigad Medical Association, IMA Ulve, and Rotary Club of Panvel Industrial Town. More than that, I can see the woman power. You see Chitra madam, Sunita madam, Nilima madam, Neha, Amuk, and many others who have been regularly contributing to the cause of child care. I must apologize for two things. Number one, um, Chitra madam asked me way back about uh, adolescent emergency care. I said yes. Then when I went through, and then she said, Dr. Minaj,
याला बघायला जायचं रे नरेशचा फोन येते तू रमेश
Dr. Minaj, don't discuss the common things like the things which are common in adolescents like anemia.
अरे नाही बोलायला सांगितलं ना आता काय मग मी
Request to all the participants on this platform to please mute themselves. Oh,
Then
carry on, sir.
nutritional problems and STIs and substance abuse and all. She said, "Sir, go beyond that." Then I said, "Yes, I can do that." Then again I went through. It was so difficult. Then I said, "Madam, can we have on this?" She said, "Yes," gracefully. Then I tried my best to prepare this topic, considering what is relevant and common to us. Poisoning itself is a big topic. However, I have come to and have brought the cases which are, more common. And I must tell you, this is not my own efforts. There's a team. I have taken some cases from my own friends, including Dr. Sachin. I will tell you what is this case is interesting cases. So with this next slides, madam. Yeah. So this is what is my brief. Next slide, please. Yeah. This conflict of interest is important to us because there will be some brands, photographs, and all. Though I have masked, at the same time, we don't have any conflict of interest, neither prejudice to none. So this is what before we go proceed. So next slide, please. Yeah. We all know the poisoning in children is very important. And what is the definition of poison? The definitions of poison are two. One is medical, third is philosophical. I will talk both. A poison is defined as substance which, when introduced into or absorbed by living organism, can cause injury or death. And poisons have been there from the ages and centuries. It has been described in Atharveda, in Shastras, including Kalpasthana, Chikasthana, Uttarasthana, plus the Egyptian, Babylonian, Hebrew, and Greek literature. The poisoning is there in ages. We know the poisonous, we used to have Vishkanya. So it's been there from ages. So what is important to us? Next slide. Next slide. Yeah. So we know, as Madam was talking, the children are vulnerable and the principal victim of poisoning. Why they are vulnerable? Because of their development. The toddlers, they have curiosity. They want to explore the new things, independent of not knowing the consequence of it. On the other extremes, adolescents may know the consequences. However, they can have intentional overdoses. And we must know that under 5 children constitutes the 85% of accidental poisoning. And the rates reported of poisoning in India varies from 0.3 to 7.7%. Next slide, ma'am. Yeah. So before we go into actually what is that, how it presents, we should know what is toxidromes. So I'll touch a brief about toxidromes. The toxidromes are nothing but the constellation or combination of symptoms which represents a particular group of drug or poisons. So we have various types of toxidrome we'll talk about. They includes anticholinergic, the cholinergic, symptomatic, opioids, and others. And in general, how do we approach the next? So it is what is said is we must remember this slide. RRSISIDADEAD. So this is the basic principle of any toxic management, which includes resuscitation, risk assessment, supportive care, investigations, decontaminations, enhanced eliminations, antidotes, and disposition. So a word about next previous slide. A word about decontamination. The decontamination includes the skin, the eye, or the gut. How do we decontaminate the skin? The skin decontamination is very simple. You have to run the lukewarm water, neither cold nor warm. Lukewarm, light soap, not detergent. You can run through and you can decontaminate the skin decontamination. Thereby, there is a decrease in the absorption of the toxins. Then how you will decontaminate the eyes? The eyes can be decontaminate by the running the normal slide. So run the flush of normal slide for eye decontamination. Coming on to a word about gut decontamination. So gut decontamination has its own plus and minuses. There is two important organizations which give us guidelines. One is American Association of Clinical Toxicology, and second is European Association and Task Force for Clinical Toxicology. So these two organizations are time and again have given us guidelines how to proceed for um, identification and management of toxins. So thereby, with regard to gut decontamination, there is no actual evidence. There is no evidence, and neither you can have the evidence because you can't have the RCTs in toxins. However, whatever observational evidence is available, thereby you can do it by what is called as catharsis or emesis or whole gut irrigation. So catharsis can be given by your, the lower GIT catharsis can be given. Emesis, it's its own indications and contraindications, and whole gut irrigation. A word about enhanced elimination. Once the toxins is in, the toxins which are renal excreted can be undergo enhanced elimination either by forced diuresis or by extracorporeal therapy. Next is antidotes. Please understand, not many poisons have antidotes. Very few have antidotes, like benzodiazepines have flumazenil and others. So we have to, it's really not easy to handle a toxins. Next slide, please. So as I was talking about, there's a group of toxidromes include anticholinergic, cholinergic, opioid, sedative, sympathomimetics, and others. And then you have, their symptomatology. So to make the life simple, this is the next slide, which you have anticholinergic toxidromes, which is caused by atropine, scopolamine, glycopyrrolate, chlorpheniramine, and others. And you can have increased heart rate, some change or no change in respiration. You can have increased temperature in anticholinergic toxidrome. The pupils are dilated. The bowel sounds will be absent, and the child will be dry. So anticholinergic toxidromes basically dry. Whereas cholinergic, there will be some change or no change in the heart and blood pressure and respiration. However, here the pupils are pinpoint and the bowel sounds are increased. Plus, they are wet. So cholinergics are wet, anticholinergic dry. Then comes the opioid, which is caused by morphine, codeine, tramadol that we usually use, mephedrine, fentanyl, and here there will be bradycardia, depressed respiration, hypothermia, pinpoint to people, absent bowel signs, and they may be wet as well. Sympathomimetics are caused by agents which has increased catecholamines and sympathomimetics like caffeine, cocaine, amphetamine, and others. Here you can have increased heart rate, tachypnea or bradyapnea, increased temperature, dilated pupil, increased bowel sounds, and diaphoresis. So this is the background. But then please understand, not all the child will have, we have to be really careful what. So these are the things at least you should look at: heart rate, respiration, temperature, pupils, bowel sounds, and whether they are dry and wet. So these are few toxidromes which makes the basis of some approach for the toxins. So next slide. Then here comes the pediatrician. He is Bahubali. He has to look after OPD, vaccination, growth and development, adolescents, LACS call, and then toxicology, which itself is a science. So having gone through the medical school, done all those sympathomimetics and nicotinic, muscarinic, all the receptors, now we are in the clinical practice. So let us begin with the case discussion. So we have the case. There is a 1.5-year-old toddler, history of having drank accidentally bottle of crocin syrup. Ingestion occurred within 1 hour. Very important, the time of ingestion. And mother has brought the child. Next, please. The child is anxious, mild tender abdomen, some tachycardia, RR28, and blood pressure is maintained for this child. Next slide, please. So it's very important, paracetamol. The paracetamol is a very good antipyretics. However, we have to be careful because there are various types of formulations which are available, particularly when you talk about drops. Whenever you give drop, be careful. I had a child during my fellowship program wherein we said give zero point 0.6 ml of drop. 1 ml contains 100 milligram, and that mother kept on giving 6 ml of that drop, and the child landed with acute liver failure, and we listed that child for liver transplant. Luckily, the child recovered. That is my first hand experience with regard to paracetamol poisoning. So whenever you, the mothers nowadays, mothers are very much, they half listen, half no. They are in everybody is in like urgency or emergency. So first thing, when you write properly, 0.6 ml, zero point 0.4 ml. First thing, avoid drops. If you give it, ensure that you are telling it is like this, and ensure that they're giving point, not the 6 likewise. So the formulation, so give the proper formulation, write properly. You have, as I said, right from drop to 5 ml 120 milligram, 5 ml 250 milligram, and whatnot. I think some 5 ml 500 milligram is also coming, I don't know. But first look at the what concentration is given. Next, then what question should I ask? The questions are, and what should I do? So next slide, please. So dose, the toxic dose of paracetamol, actually the safe dose is 75 to 90 milligram per kg. So you can use 10 to 15 milligram per kg per dose, 4 to 6 hourly. That's the safe dose. The toxicity can appear above 150 milligram or above 100 milligram. However, the lethal dose is above 150 milligram per kg. So this we must understand. Whenever we give paracetamol, see how much dose one day we are giving. Calculate it. One more thing, people give parental paracetamol at the dose of 15 milligram IV paracetamol. You can give, but give 5 to 10 milligram per kg. And oral dose is 10 to 15 milligram per kg. Not more than 100 to 120 milligram per kg per day. Then what should I do? You can give activated charcoal, 15 milligram start, and then next slide, please. Later on, NAC. NAC is N-acetylcysteine. We'll come to that. So how do I treat the paracetamol treatment? This is called as Ramsek nomogram, wherein if you see the left side, is it my cursor is visible? No. My cursor is visible? No, na? No. Okay. So on the left side, if you see gray zone, it's up to 4 hours. So this nomogram is not recommended below 4 hours of ingestion. This nomogram is above 4 hours. On the y-axis, you have blood paracetamol concentration on two ends. On the right side of the screen is in milligram per liter. On right of, on the right of this, when the hours is 24. So if you see on the y-axis, right side, blood paracetamol concentration in milligram per liter. On the left side, micromoles per liter. So whatever, first ensure that your lab is giving in what unit, and any level above the line, red line, is to be treated. This is very simple nomogram if you had. So this nomogram, next slide. This nomogram, next please, is applied only to previous. This nomograms only applies only to single acute paracetamol injection of immediate between 4 to 18 hours, not beyond 24 hours. Does not apply to co-ingested. Suppose you have paracetamol with ibuprofen or mefenamic acid. No, that's not. And not useful before 4 hours or after for 16 hours. This is what a simple nomogram which can be used for paracetamol poisoning. Next slide, please. And the effect basically is on the liver. It causes liver injury. Next slide. And you have the stage 1, stage 2, stage 3, stage 4. Stage 1, from time post injection up to 24 hours, you have anorexia, nausea, vomiting, and OTPT may start to rise. Next stage, 24 to 72 hours, may see improvement in clinical finding, or some patient may report elevated AST, ALT, and right upper quadrant abdominal pain. Day 3 to day 4, hepatic failure, acidosis, renal failure, pancreatitis. Day 5, may progression to multi-organ failure, and sometime it may be fatal. However, if we start the treatment within 8 hours with NAC, the outcome is really good. So we have to be like, early identification, early intervention, and a good outcome. Next slide, please. This is all about paracetamol poisoning. We'll go to next course. This is another important thing with regard to child who are below 5 years of age. He is sitting in the place where all the containers are being kept. A 2-year-old child brought by the parents who was found with container of drain cleaner at his home, and something was there in his hand and some around the mouth. Child is otherwise asymptomatic. Physical examination is normal, including oropharynx is normal. The dose, how much is taken, really we don't know many time. So what are you going to do? Are you going to reassure the parents and tell them to follow up gastric lavage or what? Next slide. So bottom line is, for drain cleaners, oven cleaners, toilet cleaners, do not lavage. These are, castics, strong and weak castics. Do not lavage, do not give activated charcoal. So what we do, next slide. So these are actually, acids and alkali. They are strong and weak acids and strong and weak alkali. They causes coagulation necrosis. Previous slide. Previous slide. They causes coagulation necrosis, stomach injury, liquefaction necrosis. So basically, they causes the protein denaturation. So over a period of time, then one can get the sequelae in the form of stenosis, the esophageal narrowing, and all those things. That we have to keep in our mind. Next slide, please. So castics, can we really predict the degree of injury? The answer is no. Next slide. So what? Next slide, please. So for the castic injury, what are the options available? The endoscopy, the steroids, the antibiotics. Next, endoscopy can be useful, but not indicated always within 24 hours. Not indicated. Steroids, controversial, depends on the degree of injury. Antibiotics, based on the whether the child is aspirated or perforation, and if you have pneumonia, then one can, otherwise no. Next slide. So some more cases, rapid fire. We have a child who has all out, good night, 1 ml is also bad. Next, the poison in the rat, the poison allowed is parathyroids plus alcohol. You don't have to give any lavage. You just have to observe. If the seizures are there, treat. It has the effects on liver and cardiac. Next, the kerosene, the hydrocarbons, volatile, no lavage, no charcoal. You can do the X-ray after after 6 hours, within 24 hours, because it can cause what is called as hydrocarbon pneumonia. So you can do that, and it can accordingly have to treat. Rat poisoning, very important. Next slide. So the rat poison contains zinc oxide plus. There you can use activated charcoal, and it causes renal injury, it causes liver injury based on the degree of poison taken. So accordingly treat. So you have acute kidney injury, you have acute liver injury. Kapoor, very common. Camphor, next. So camphor is also poisonous. There is no specific antidote for camphor. We can use activated charcoal for binding with the camphor binding activity charcoal, and symptomatic treatment in the form of midazolam and phenobarbital if seizure occurs. Next slide, please. We go to next case. A 5-year-old who is crying and rubbing at his arm, telling that get the bug off from me. Comes to your clinic. He's febrile, tachycardic, blood pressure maintained, flush skin, pupil dilated, extremity is warm, CNS examination is unremarkable. So what toxidromes we are dealing with? This is, next slide, anticholinergic, datura poisoning that we talked about in the before. So what do you do? So case we approach, we have done the gastric decontamination with charcoal, supportive care with benzodiazepine, antidote the physostigmine. Indications of physostigmines includes coma, unstable vital signs, and the dose thereupon. Next slide. This is the interesting case. A 13-year adolescent girl brought to casualty with chest pain since 1 hour. Drowsy, but responding to command in pain. Heart rate 100, temperature 100, heart rate 148, tachypneic, hypotensive 78/40 for 13 years hypotension. CRT is 2 seconds, skin is flushed, no significant past history or any associated cardiac complaints. Next slide. On further questioning, she said that she is depressed, there's some issues in the school, and she consumed half bottle of her mother's pills, amiton. Amiton is amitriptyline, TCA, tricyclic antidepressant. She was given oxygen volume resuscitation because she was hypotension. Her ECG revealed wide complex tachycardia. It can cause tachycardia, which can be like wide complex means ventricular tachycardia. The indications of soda backup in TCA is wide complex tachycardia, which was given to this child. And next slide. She responded with the volume resuscitation. She had seizures, received lorazepam, received noradrenaline, and with supportive treatment, she improved. Next slide. Next slide. Next. So we come with this. Now we come to stings and bite. A 7-year-old boy developed rashes and wheezing following a bee bite. So what is happening over here? Anyone? This is anaphylaxis. Immediately after bite, there is some degree of anaphylaxis. So how do we approach it? Next slide. Next. So when to suspect? Acute onset, minute to hours, involving skin, mucosa, and or both, and at least one of the following: respiratory compromise as difficulty, increased work of breathing, wheezes, bronchospasm, hypoxemia, or hemodynamics involvement as low blood pressures, signs of end organ hypoperfusion, syncope, and persistent GI symptoms as cramp, abdominal pain, vomiting, diarrhea. So here you can suspect anaphylaxis, acute onset. And how do we treat? Adrenaline. You can repeat adrenaline. The dose of adrenaline is 0.01 ml per kg, maximum 0.5 ml. Repeat every 15 minutes. Along with adrenaline, we can give diphenhydramine and hydrocortisone. So anaphylaxis is an emergency which everybody should know, and we should be ready in our OPD practice as also. Next, please. So a word about few common bites. So beetle sting. Wash with soap, water, avoid contact with eyes, give analgesics, anti-allergics. Next, severe rare. Next, so wash with soap, apply betadine, and here they recommend rabies vaccine. The big rat in the sewer can carry the germs for the rabies. So they recommend if you have a rabbit, if you have a severe rat, you have to give vaccines. Do not suture. You can give tetanus and If the wound is high, you can give antibiotics. Another common thing, child biting another child. What to do? Clean, wash with pyridine. If required, is a big, small bite can be like wet left. Bigger bite, you can have the surgical correction. Tetanus, antibiotics if required, and parental counsel. Next, please. This is interesting case. This is the actual case which has been shared with me and managed by Dr. Sachin Jangam, who has been trained at Wadia and now working at Sangli. Very interesting case. A 14-year-old adolescent girl was working in kitchen around 10 p.m. She presented with abdominal pain followed by 2 episodes of vomiting. While vomiting, she choked and had difficulty in breathing. She was taken to nearby hospital. Next, please. She was tachycardic. Heart rate was as high as 200 plus. Had low saturation. However, sensorium was normal. And for low saturation respiratory failure, emergency intubation was done. Next. Within half an hour, she became unresponsive. Pupils were dilated, fixed, and non-reactive. And the referred to higher center to Sachin's place as brain death patient. The differentials at that point of time was kept as encephalitis, though there was no fever. IC bleed can happen, pneumonia, and poisoning. The video. See, the pupils were dilated, fixed, non-reactive. And Sachin thought important thing was there that this
Vinay sir, Sunita ma'am.
Yeah,
Yes,
फोन
yes.
करके देखो सर को फोन करो सर इज डीलिंग
yeah.
Okay,
I thought it was,
I got disconnected.
yeah, internet.
Is he rejoining?
Who's calling? Yeah.
मैं करता हूँ
Acha.
सर नंबर इज गेटिंग बिजी
Okay, okay. In between, you please request the audience to put on the questions in chat box.
Very excellent session.
Yes.
Actually, sir, is a very informative session is going on. Very informative about all the toxins, sir. The information is giving by sir.
Yes. Sorry for this disturbance. We will get back soon. And if anyone has got any questions, I request them to put it in the chat box. We can take it later if we have
Yes,
time.
sir is connecting again.
Yeah. Yes. Yes.
Neha, please share the link of this session. Huh? It is very useful. Even on YouTube link, please share.
Yes, ma'am. Maybe today evening or tomorrow morning
Yes,
we'll.
yes, yes, yes.
Yes.
Any other office
Sir has
bearers?
joined.
They are
Okay, sir
present.
has joined.
Yeah.
Am I audible?
Sir has
Yes,
joined.
sir.
Yeah.
Yeah.
Yeah. Please, uh, madam, can you please go back to the slides? My sincere apology. I don't know what is happening today. I'm really sorry. Yeah. Yeah. Go back. Next slides. So, next slide, please. Yeah. Next slide, madam. So this child received anti-snake venom. Within, like, she was not well for the next 4 days. However, she started having a recovery and she has a complete recovery next 4 hours, 4 days. Following recovery, she told that, she had gone out at around 7 p.m. when there was a small rod with lots of grass, lots of grass. So she holds something on the grass. She thought something bite on her hand, but she could not see anything. And she developed symptom within 2 to 3 hours later. Next slide. And this a girl in the yellow dress is the one who has recovered, was sent as a brain death patient. So good clinical judgment and suspicion of poisoning is very important. Next slide, please. So these are the various side types of uh, we in India usually we have 200 types of poisonous. Of the 200 types of snakes, of the 200, around 52 are poisonous, and there are two categories of snakes. One is neurotoxins, and uh, one is vascular toxins. So vipers are usually vascular toxins, and others are neurotoxins. And sir has rightly said it was crate poison which has caused all these things. Next slide, please. So how do you approach to a case of suspected snake bite? You can have overt bite or you can have occult bite. In this case, it was an occult bite, wherein the common cause of occult bite is crate poison. It has neuropalatic symptoms with no local signs, abdominal pain, vomiting, and the treatment is ASV. You can give atropine or neostigmine, and you can use symptomatic as ventilation. When you have overt bite, the history of bite, and 70% of them are non-venomous, non-poison. 30% are poisonous. So non-venomous, asymptomatic, anxiety, palpitation, take care of that. Venomous, you have two types of bite: dry bite and wet bite. What is dry bite? Is that actually the patient the snake has bitten, but the venom is not inoculated. Venom is not delivered. So you can have everything, but you don't have the venom. That is dry bite. It will go into the asymptomatic pathway. In the symptomatic pathway, you have four categories: progressive painful swelling. As I said, it is mostly vasculopathy. So viper, you have local necrosis, ecchymosis, blistering, painful swelling, compartment syndrome. You have to give ASV. Neuropalatic, you can have cobra crates. Here you have 5Ds and 2Ps. You remember 5Ds and 2Ps. The 2Ps ptosis and paralysis of your third, fourth, and sixth cranial nerve pulses. And Ds are diplopia, dysarthria, dysphonia, dyspnea, and dysphagia. So these are the progressive symptoms which can happen. 2Ps and 5Ds. Here again you have to give ASV and ventilation. The vascular toxics, the Russell viper, they have bleeding, DIC, shock, AKI, injury. And then myotoxic, you have flat tail snake bite, muscle ache, muscle swelling, involuntary contractions, and compartment syndrome. Here you have to give ASV. Next slide, please. So the first aid is recommended as right. What is right? Is that next slide? Next slide. It consists of reassurance of patients. Reassure. Not all the bites are venomous, poisonous, but at least keep the options open for poisonous as well. immobilize in the same way as fractured limb, get to the hospital and tell to doctor of any symptoms. Next slide. So this is the way we usually immobilize. What is not to be done in poisoning is, go ahead, do not apply tourniquet. This is the first response that we apply tourniquet. Do not apply. Why? It will cause ischemic necrosis. Once we remove the tourniquet, there will be a flush of toxins and the symptomatology report. So do not apply tourniquet. Do not attempt to suck out venom with your mouth. Do not make cuts and incisions, because what happens if it is a, if you have a uh, bitten by the vipers, so it will cause a lot of bleeding. So do not cuts. Do not wash with the soap and other solutions. Do not give electric shocks and all, and do not freeze or apply any cold area to the bite. So these are the things which are not to be done, which is usually done. Next slide. Going back to basic pediatrics, in any sick child, including the patients of poisoning, first you have to have initial impressions. This is very important pediatric assessment triangle, which has three components: appearance, work of breathing, and circulation. Appearance takes care of your CNS part, work of breathing takes care of your respiratory part, and circulation takes care of your hemodynamics part. This has to be looked after at a first contact, anywhere in the OPD, in the ward, in the ICU or casualty, wherever. And you have to identify whether there is a life-threatening situation, whether there is respiratory distress or respiratory failure, whether the child is in shock or no shock, or whether the child is encephalopathic or no encephalopathic. So we do initial impression, we do primary assessment, take proper history, and do ABCDE approach. So what is the ABCD approach? Next slide, please. Next slide. So remember to secure airway, give oxygenation if required, intubation as may be required, case to case basis. Circulation, maintain blood pressure, give fluid therapy, calm yourself and patients, check care of glucose, check pupils. Pupils are the gateway of the brain. Take care of electrolytes. Next here, next please. Fluids, take care of the family, take care of the fever, assess GCS. If you have signs of raised ICP, you can hyperventilate, look for signs of herniation and ICP monitoring based on the case to case basis, not on all the cases. A word about disability, you should look after disability. We use AVPU scale or GCS, people response to light and blood glucose test. Next, this is what APU scale with the GCS. Okay, if you're alert, it amounts to 15 GCS. If you are communicating, it amounts to 13 GCS. If you're responding to painful stimuli, it amounts to 8 of GCS score. And unresponsive to noxious stimuli, it amounts to or equal to is GCS of 6. Next slide, please. To conclude, poisoning can be sudden and unexpected. Recognize it as an emergency. Have an ABC approach. Be prepared either in the OPD or in the nursing home with equipment and drugs. Very important. Timely, appropriate referral and safe transport is recommended, and seek help if needed with National Poison Information Center. Next slide, please. Thank you. Next slide. Next, please. Next. So to acknowledge, as I said, I have next, please. Previous slide. Previous slide. Previous. Dr. Neha, previous. Okay, we can conclude. No problem. So I'm open to questions now.
Yeah.
Yeah. So
Uh,
I have the slides is taken from like couple of cases are from my friend Maninder, our own Sachin, as I said, and I'm trained the photo on the top right is where I'm trained at Gangaram Hospital, and presently in the down is where I'm working with my team. The nurses are the backbone, and then all of us. Thank you.
uh, Thank you so much, sir. It was absolutely informative and very clear cut, means very comprehensive and very, we could understand everything so well. Very well illustrated too. So there is a question in the chat box, like
Yes.
someone has asked, please throw some light on gas geyser poisoning, sir, because it's very commonly used these days.
Yeah, gas geyser poisoning. What happens usually? It causes inhalation type of poisoning. So basically respiratory and CNS. So you have to take care of respiratory and CNS symptomatic treatment. Nothing beyond that. No specific treatment. So
Thank
first
you,
thing
sir.
you have to prevent it actually. You have to prevent actually because it causes more of uh, inhalational type of injury. So it's very
Right, right.
important. It's very good question. Very
Yes.
yeah.
Yeah.
Yeah,
Another
sir. We
question
had
about
Carbon
two
monoxide.
naphthalene ball
cases.
poisoning. 1 minute,
Yeah.
Chitra. There is one more question which just come on. Naphthalene ball poisoning. He's asked to throw some light
Naphthalene.
on.
Yeah, naphthalene again. I think I'm not sure, but whether it comes in the group. I'm not sure. Anybody can say because it's again symptomatic treatment. Again symptomatic.
Okay, sir.
Purposefully, I have not included because you can have so many things. I tried to be
Yes,
within
sir.
45 minutes, whatever we can
Yes,
have.
sir.
But yes, naphthalene ball is again very common and it comes like symptomatic treatment only. Yeah.
Sir,
I
mainly it
have
is a
see these are
this
I can give
this
this is one good book which is there. You have this good book is there. You can have so many things in that is available uh in the what is that Amazon. Just 400 500 rupees book, but lot of information is there. Poisoning in children, Utpal Khan Singh.
Okay, sir. Uh, Sir, I have one question regarding this substance abuse overdosing also, which is teenagers do. So, because of the new drugs coming in, I mean, how do you go about with the same type of syndromic approach, or how do we know what kind of substance they are abusing or using, sir? The teenagers, especially the adolescent. Oh, sir is left.
No, he's
His connection is left.
then he's rejoining.
Please go ahead.
Yes, sir.
Yes, Sunita
Sir
madam,
is with
boliye.
us? Sir,
Yeah, I'm there.
regarding the ODs in adolescent, they are experimenting with newer drugs also, and they overdose on those too also. So, I mean, what are the drugs which they use mostly, and how do we suspect it? Unless there's a clear-cut history, it's okay, but if not, then what?
Basically, that is that will come as a symptomatic syndrome.
Okay,
So,
sir.
first thing is adolescent behavior. Adolescent behavior.
Yes, sir.
Uh, Adolescent behavior is important, whether they are normal or going away from their behavior. Second is uh, unexplained hypotension. Okay, if they're coming with that in acute emergency, not in a office practice, then and they will come as a sympathomimetic toxidromes. So cocaine, LSDs, they all come as a sympathomimetic toxidromes. So there you have to go that pathway.
Okay, sir. Thank you. Are there any
With
more?
regard to gas geyser, carbon monoxide poisoning is one which we is the one. Then we have to treat with the pathway for the carbon monoxide poisoning, including your hyperic oxygen, which is not available with us.
Okay,
Yeah.
sir.
Yes, sir.
Any more questions? So we may take one or
Hello,
two.
Vinas, sir.
Yes.
Hello.
Go ahead, sir. Go
Yeah.
ahead, sir.
Yeah.
Madam, organophosphorus poisoning is very common in particularly in rural area or farmers' home. It is easily available and lying on the ground on the floor also. So this type of poison is very common in particularly in peripheral area. A few
Yes.
years
Yes.
back we had this incidence nearby Khopoli in Mahad.
Yes.
So, about 20-25 children were poisoned actually with organophosphorus poison. That is 4-8 poisoning.
No, organophosphorus is a big problem. I mean, not only it has an acute poisoning, it has an intermediate, it has a long term. So organophosphorus, actually, I don't know. The problem is it's easy availability.
Easy
It's easy
availability. Yes.
Easy because it is required for the agricultural use, the carbate. the
Right.
carbamate. So that is actually it has issues. It has a concerns. Yes. Yeah. Anything
Any more
else?
questions?
Any more
No.
question? See, I
Anyone
tried.
wish to?
Yeah. Yeah. Please.
No, sir. I'm just looking. If anyone has any questions, can ask. Dr. Vikas, go ahead.
Yeah. Sir, it was a wonderful presentation. Uh, when a child comes to office practice or when child consumes something, there is a tendency to induce the vomiting. So, if the audience know that when to induce and when to not to induce the vomiting, because the poisons like corrosive poisons or kerosene, it
Yes.
may cause more harm than help.
Yes.
So, the distinction has to be made. So, for the benefit of audience, kindly deliver on it.
You know. Yeah. It's an interesting question. It's a very important question because uh, it's a reflex to this is called as gut decontamination. I was on the gut basis. If you go by
Sure.
the recommendation, by the standard recommendation by the society, they say in specific cases, not in all the cases, you can induce, but not in all cases. Can't do in the hydrocarbons. So all those places, it is not recommended. Evidence is not there for them. They say there is no evidence to support uh, to induce images.
Okay, Dr. Vikas,
Sir,
you can sum up what was told by sir in the presentation. Dr. Vikas, probably sir's connection is not proper. So you
No,
can,
I'm there. I'm there.
yeah, sir.
I'm there.
Yeah,
Sir,
yeah.
I'm there.
I request
Yes.
you to put off your video so that your bandwidth probably
Huh,
is low. So
huh.
we can hear you properly if you put off your video.
Yeah, I did that. I did that.
Yes, sir.
So
Sir, continue.
yeah, one of the way we can use the we can induce the emesis by EpiCap, EpiCac. So EpiCac induced emesis is useful if administered within 1 hour of injection. Beyond 1 hour, it is not useful. However, you have to keep that it has own complications as aspiration. So current, guidelines given by American Academy of Clinical Toxicology and European Association of Poison Centers and Clinical Toxicology suggest insufficient evidence for the use of emesis.
Mina sir, I have one question. Dr. Jay here.
Yeah. Yes, sir. Good evening, sir.
गुड इवनिंग सर, ये बताइए व्हाट अबाउट द एक्टिवेटेड चारकोल, विच इज फ्रीली अवेलेबल, कैसा यूज करना है? एंड
Activated charcoal it's available. It's available as tablet, okay? And we do use as a stat 50 gram. We do use. So this is what is activated charcoal? It is an inert, non-toxic, powerful substance which bound to intraluminal drug.
Right.
Intraluminal drug by forming irreversible bonds. Okay?
Okay.
So, it has to be given in the proportion of 10:1. That means 10 part of charcoal, 1 part of drug. If you know the drug, the dose which has been like ingested, which usually we don't know, but the proportion which has been prescribed is 10:1, and it is to be
Right.
given preferably within 1 hour. Within 1 hour. So
Right.
what they say, single dose regime versus multi-dose regime. So you can give single dose 50 gram to 100 gram given start, or multi-dose regime you can give 50 to 100 gram given every 2 hourly to 4 hourly.
Okay.
And the multi-dose regime is useful for drugs with significant intrahepatic circulation, like opioids and TCAs.
Okay.
Again, when we use activated charcoal, we have to take care of airway loss, risk of aspiration, and some poisonants
they're not absorbed by the charcoals like organophosphorus, potassiums, alcohols, acids. These are the hydrocarbons, iron. These are the ones which are not absorbed by the activated charcoal. So we can, there's a
Right.
role of activated charcoal, but it has to be on a case to case basis. So which are
Right.
the drugs which are, which can be used activated charcoals? Like for example, your carbamazepine, dapsone, phenobarbital, quinine, theophylline. There we can use activated charcoal. Where in phenytoin, digoxin, the role is unclear.
Okay.
Yeah.
Thank you.
Sir, I have one question.
Yes, madam.
So we lot of the times see that this combination NSAIDs is
Yes.
given to the children to get better relief of their hyperpyrexia. So have you encountered
Yes.
any cases of ibuprofen or other NSAIDs which is causing problem and problem of overdose especially?
Honestly speaking, the one which we usually just I have encountered is paracetamol, but yes, there have been you can have brufen overdoses also, the ibuprofen overdoses also, and it has an effect on the kidney, basically nephrotoxic. It is a potential nephrotoxic. So I have seen a patient who had, and one important thing with the brufen and nephrotoxicity is that it is not dose dependent. Very important. It is not dose dependent. Somebody who is susceptible for nephrotoxicity caused by brufen can have in the lower doses also, may not be in the toxic or the lethal doses also. So that's why our drug of choice for fever is, very honestly, is paracetamol number one. Number two, adequate hydration. Number three, tepid sponging. And yes, honestly speaking, sometime SOS basis pe, I use 5 milligram per kg, not 10 milligram per kg. People use 10 milligram per kg of brufen. The dose is 5 to 10. I use 5 milligram per kg 8 hourly SOS. Very honestly, 5 milligram per kg. That's what.
So
No.
yes, sir.
But
The duration is also different.
yeah.
No, for paracetamol we can give 4 or 6 hourly, as against for NSAIDs, especially ibuprofen, it is always at 8 hours
hourly.
interval.
8 hourly. The problem is that when you have a combination, see, I'll tell you one thing. This FDCs, fixed drug combination, is only available in our part of the world.
Yes.
And no fixed drug is rational. I mean, with due respect. Either the thing is either under or overdosing. So,
सर ये
you right. Yeah. Yes, sir.
सर
Yes, sir.
सर मेफेनेमिक एसिड और पैरासिटामोल का कॉम्बिनेशन बहुत फेमस है कॉकटेल लोग
Sir,
दनादन
बहुत
लेते
डेंजरस
हैं
सर. बहुत
बहुत
डेंजरस सर.
dangerous है. People use
Mefenamic.
below 1 year or so. Even I've seen the prescription for infant below 1 month, right? Actually, when these drugs are available, it is not rational. How it is available in the market or for a use? Whether government do something for
Sir,
this, right? अपना अपना
you know,
FDI
sir,
क्या कर रहा है?
you rightly, sir, you rightly said mefenamic acid तो मैंने जिंदगी में I don't know how many times I have used.
नहीं sir, why
Rarely
it
I
is
have used.
like combination why it is available is
And
no
number
rational.
one, sir, it is, it goes to other level, the policymakers and the business and so many things comes in. So that is the problem. Otherwise, there should not be combination like mefenamic acid and the paracetamol. And believe me, sir, we have so many patients of fever and all. If you give paracetamol in adequate doses, adequate duration, it does response. And hydration.
Or basically paracetamol has a huge safety margin, right?
Very huge
150
safety
to
margin, sir.
150 to 200 milligram per kg तक वो दिखाए तभी हार्डली कुछ सिम्टम्स आता है उसमें पेशेंट.
150 up to 150 is very safe, sir.
Right.
Very safe. We
Because
calculate another important thing when we calculate by up to 40 kg.
right.
And then we have a child of 60-70 kg. Don't go by 60-70 kg. Go up to 40
Right.
kg. Above 40 kg, everything is like adult.
Right.
Everything is like adult. go by what? Suppose my child is 60 kg, if I am doing 10 milligram, so 15 milligram per kg per dose of paracetamol, it will go way beyond. So
Okay,
go by the
almost
above 40 kg, go by the, like, what we do.
because almost every
Yes,
month
sir.
you get a phone call for some pair, and actually we should give proper instruction. The parents keep all this all medicine, because all pharma companies are in the competition to have a good taste of the medicine, and our poor pediatric patient doesn't understand it. They gulp bottles sometimes, many
Yes.
times. Hmm.
Point well taken,
Because
Dr. Jai.
that's very important. That's very important because, not only that, not only the, if you see the, I don't want to name the brand, but it's so attractive. The bottles are so
Yeah.
attractive, very
Uh,
attractive. There's a cough syrup having a, pinkish color and all, and so it's really attractive.
Yes, sir. All bottles are attractive.
Yeah. No. I mean, I understood what you meant to
I
say.
think we have had.
We have, I
No,
think,
we are
finished our
running.
time.
Yes, we have to finish now. So over to Dr. Chitra for vote of thanks.
Yeah, thank you very much. And I really appreciate the efforts taken by our esteemed speaker, Dr. Minas Sheikh, sir, and his eagerness to share his knowledge. Thank you very much, sir. I also thank President Dr. Arun Bhagat, Raigad Medical Association, and Secretary Dr. Rajesh Sapkat, as well as Secretary IMA Ulve, Dr. Krishna Borkar sir, Dr. Vikas More, our President of IIP Raigad, as well as IMA Raigad, our ex-Vice President RMA, Dr. Rahul Veer, and ex-President of Navi Mumbai Doctors Forum, Dr. Arun Pure, as well as Rotary President and our Raigad IIP star member, Dr. Jay Bhandarkar, for joining and taking active part in today's session. I thank Dr. Neha Singh, who is doing multiple talented activities as well as sharing her knowledge to us. Thank you very much. I also thank moderator Dr. Sunita Ingre for taking out time and moderating the session. I thank Treasurer Dr. Pradeep Atkari for spending time for this webinar, and also Dr. Vishal Raut, who is silently helping us throughout our year sessions. Thank you very much. Over to Dr. Sunita.
Thank you, Chitra. So now we conclude the session. Goodbye, everyone.